Good morning from Miami. This is Dr. John Bennett for Neurosurgical TV. We have the 7th episode of Neurosurgical Super Sunday, and we have the pleasure today of having Salman Sharif, a noted spine surgeon from Pakistan and conference organizer. Before we turn over to Salman, let's meet some of the panelists. Good day, Adnan. Could you please
Good
introduce
day.
yourself?
Nice to meet you. Okay. Good morning. I'm Adnan Mohammed, neurosurgical resident in Egypt. Yes, for the second year. Nice to meet you all. Good morning.
Okay, welcome Adnan and Andrea.
Hello, everyone. Nice to see you.
Welcome.
Could you please tell where you practice and stuff?
I am an Italian neurosurgery resident, third year in Novara near Milan.
Okay, welcome Andrea. And Slaven?
Hello, I'm Slaven. I'm a senior medical student from Zagreb. I'm also leading the Dandy Club here and cooperating with some neurosurgical clinics, and I'm really happy to be here.
Welcome Slaven. Joseph?
Hi, Dr. Salman. I'm a final year medical student from Dawn Medical College, and nice to see you.
Here, welcome Joseph. And the Russian contingent, I don't know if someone can introduce. There you go.
Hello, do you hear me, Dr. Bennett?
Yes, we do. We see you and we hear you well.
Tumen Medical Neurosurgery Center. Nice to see you again, and hope we can see you. There aren't so many people today because it's some kind of celebration.
Okay.
This.
Welcome. Okay, and I'm John Bennett from Miami, and we'll turn it over to Salman. Welcome, Salman.
Thanks, John, and it's brilliant to be back on Neurosurgery TV, the ACNS Super Sunday, and it's good to see so many of our old and new friends there. I have some of my residents connected as well, but they didn't want to be on the panel, but they just wanted to see, so that's fine. That's with us as well. Hopefully next time we should be able to have a scenario like what we had about a month ago, when we had the residents in a conference room and we were able to do the same thing what the Tumen people are doing. But you know, it's good to be with all our friends all over the world. Well, see the slides. John, can you see the slides?
Yes, we can. I'm sorry, I was muted. Yes, we can.
Okay, so although I'm a spinal surgeon, but I have a keen interest in minimally invasive brain surgery. One of my favorite topic is endoscopic pituitary surgery. I've been doing this for last 12 years, and it's been some time since I've had any craniotomy for pituitary, even if it's a giant tumor. Majority of them, we can get them out through the nose. So this talk is actually focused again for medical students and residents. And the talk will focus mainly on giant pituitary adenomas. But first part of the talk is for patients to select how do we start, what do we do with these giant tumors. Well, again, greetings from Pakistan. As you know, it's a beautiful country. This is K2, which is the second highest mountain in the world. And this lake is Lake Saif al-Muluk, one of the highest lakes in the world in the Swat Valley. This is an amazing part of Pakistan. Well, I'll be talking about tumors like these, which we see because many patients come late and many patients don't realize the problems they've had, or patients have an apoplexy and all of a sudden the tumor increases in size. So these are giant tumors which are more than 4 centimeters in height, or then we talk about volume, so they're more than, we say, up to 20 milliliter in diameter itself. So these are different kind of giant tumors, but you know, all of them are labeled as one, and some of them you may need to just do if the carotid artery is engulfed. You may not need to take all of it out from inside. You can leave some of the tumor behind because you don't want to be risking these patients. But every patient that you do, you need to see the pituitary gland, where exactly it is. and you need to know beforehand in order to have a good outcome, which is a good functional outcome from endocrine perspective. Obviously, it's done under general anesthesia with intubation. Patients are kept supine with trunk 10 degree elevated, but you can do various ways, whatever you're used to. I generally turn the head 10 degrees towards myself. And you have to have good friendship with your anesthesiologist, otherwise you could be in serious trouble. You need to have controlled hypotension and excellent analgesia, because you don't want to have mucosal bleeding while you're working with an endoscope without a speculum in the nose. Position, obviously the inclination of the head in the vertical position varies depending on the function of the anatomy of the lesion. For example, if the lesion is in the sphenoid sinus or the clivus, the head is slightly flexed. Whereas if the lesion is in the planum or suprasellar, then the head is moved to a neutral position or slightly hyperextended. The whole idea is you don't want your scope hitting the chest itself. I'm not sure if I'm okay here. 1 second. Yeah.
You're still on the first slide, Salman. Do you want to stay on the first slide?
It's okay?
You're still on the first slide.
Oh, really? I think I'm moving here, but for whatever reason, can you see this?
Oh, yes.
So maybe I'll just stick to this and increase this slightly and go like this. And throat packs have to be carefully applied by a senior anesthetist. Why senior? You don't want these people to be having some kind of abrasions in the throat. You don't want to be having.
Yeah, man.
Can you all see this?
Yes, we can.
Good. And you don't want to be having an increased ICP or a CSF leak afterwards because of vomiting or coughing in these people. So, and your anesthetist need to suck the nasopharynx, oropharynx, and the stomach in the end if you've had some kind of bleed that's gone through the throat pack. Obviously, you don't want to be selecting acromegalic patients when you're starting out, and the reason, because when you look at the preoperative MRI, you could see kissing carotid arteries in some of these acromegalics because the carotids really come close. And bone is much thicker, the blood vessels are larger, they bleed quite a bit. The carotids are tortuous, and you may cause serious problems to the vessels. Anesthesia and intubation is a problem, and post-operatively you can have more bleed than usual in these acromegalic patients. So these are not the ones that you should be starting out with. Beforehand, when you do the MRI with macroadenomas, you need to see the lateral extension. You need to see the shape of the sphenoid itself, the extension, how far down is it going, how far up it is going. Is it a dumbbell at waist? Has it got a suprasellar extension or a cavernous extension? If the patient has got a hypointense T2 weighted MRI, that predicts hard consistency. You don't want that to be happening, because once you have that, you need to have a cavatronic ultrasonic aspirator. You need to be prepared that these patients, you may not be able to get the whole tumor out. So you can predict beforehand, can you or can you not take the tumor out? So when you look here, this patient has got a tumor which is going all the way into the sphenoid and then going up. And part of it is going into the third ventricle. Well, this tumor is slightly easier to operate on because half of it is below into the sphenoid itself already. So although it is giant, but at the same time, the results may be quite good here because you've got a plane to work with, and you've got majority of the tumor already underneath, and rest of the tumor falls down if you have your patients. Whereas patients like these, in which the carotids are pushed out, where the whole of the sella is dilated because of the pressure, although it's going into the third, and obviously what's going lateral to the carotid may be difficult to take out. You've got a bit of bleed there as well, and part of it is in the sphenoid, rest of it is going up, but the lateral extension is a problem here. So, a bilateral approach is generally used for these macroadenomas so that you can use both nostrils. The instruments introduced through one nostril have a medial angulation reaching the contralateral, suprasellar or parasellar portion of the lesion. Whereas when you're coming from the other side, obviously your scope and your instruments can work below that. Narrow nasal cavities or anatomical variation may make the progression to the surgery difficult. And in these patients, obviously, simultaneous use of both nostrils is really advantageous. And you can put in scope from one side or the other, or suction from one side or the other. And you can have 4 hands working together at the same time when you're doing these surgeries. Soft tissue shaver works very well throughout, and a thorough biting instruments may just provide precise removal of the septal mucosa. These are the instruments that may save the bone or may save the mucosa depending on what kind of instruments you're using. You do a posterior septectomy with backbiters, and binasal approach is easier on the sella, and it prevents the septum from brushing against the endoscope. Obviously, in patients in which we plan a flap beforehand, in which we think we're going to have a leak, in those patients, obviously, it's a completely different ballgame, which I will talk about later. This is Amin Kassam and myself, and we are just showing that if your hands are tied at your wrist, you won't be able to work. The same rule applies when we are working in the nose. So it's called a 1/2 rule. If we remove the anterior half of the sphenoid, and we take the sphenoid widely, go all the way laterally, so we can see both the carotids quite clearly. And then we clear as much as down into the sella, about 1/2 down in the sella, the clivus itself. And the idea of going down is because here your scope lies on the top, just above the plenum, and below that here your instruments are going to be working. So you don't want your instruments fighting with each other. So for example, a scope comes here, the instruments from 2 sides can work underneath into the cellar area, and you can take the tumor out without causing any problems. Haddad flap, which has come out about 10 years ago, has changed the way we work because it reduced the CSF leak ratio tremendously. And now that risk of, for example, if you're working in a planum with a meningioma, the risk has come down really down to less than 10%, which was up to 80% in a certain extent. And the idea is that you raise a flap on the medial aspect of the septum onto the vessel itself. And it's pretty simple and quite easy to do. It used to take a long time for our ENT guys, but now many times we do it ourselves, and you can see the nasoseptal artery coming, and your middle turbinate and inferior turbinate up there, and the choana down here. And this is the pedicle of the flap on which the vessel remains intact. And once you've removed that, you put this flap down into the choana. You do all your work up there. And once you have done that, you can bring the flap, and the flap basically protects any of the CSF coming down. And it's a very good anatomical repair that you can do. I'm just going to briefly show how it works. So this is a Haddad flap. And if you see here, I'm sorry, that we are removing this medial part of the septum, bringing it down all the way, and putting it down in the choana, making sure that then we are able to bring another flap from the opposite side of the septum, turn it around, and put it on the bare nasal septum, and just like that. So you bring it backwards, and you put it on the side. So idea is that it blocks, takes away all the crest that forms later on. And the main flap that you take obviously goes onto the floor, onto the roof of the sphenoid, or wherever you want the leak to be stopped. When you're doing this pre-operatively, you need to see what kind of sphenoid septum there is, and you do anterior sphenoidectomy, and you need to go as far lateral as possible. You can use punches, you can use drill, whatever you're used to. Dura is opened in the routine fashion that we used to do with microscopes. So we use Doppler or a needle, whichever you have at home. Doppler is much safer, so you know exactly where your sinus is and where your carotids are on both sides, and your sinus up and down, and you make an incision depending on how big or how far you want to be doing. So with these metroadenomas, you need to have a complete exposure of all the 4 vessels on all 4 sides, and I'll just show that in a later picture. So incision in the dura, you can do various ways. I do a cruciate dural incision with the right angle dissector to find the subdural plane around the margin of the dura. And then if you want to be taking out these tumors, obviously, when they're giant tumors, they're very, very difficult to take out via capsule. So these tumors, you need to take out inferior lateral aspect first, allowing the suprasellar tumor to descend later on. If you took out the suprasellar tumor first, the diaphragm is going to come down on you, and rest of the tumor, it would seem like that you've taken all of it out, but the tumor would be lying on both sides and you will be in serious trouble. So this lateral portion of the tumor has to be removed gently with blunt curettes to avoid damage to the carotid and cranial. And some people use Valsalva or injection of saline by lumbar drain to bring all this tumor down. Obviously, if you removed the initial part, the central part or the superior part of the macroadenoma first, this diaphragm comes down, and this lateral part, inferior part, and bit of the one from the top won't come down. And you may think you have removed the tumor, but it's going to be very difficult. And trying to resect that may cause increased risk of CSF leak in these patients. And then use an angle 30-degree, 45-degree scope to look laterally and above and make sure that you've taken all the tumor remnant out and move forward. Repair is performed with the purpose of creating a protective barrier and reducing the dead space and preventing the descent of chasm into the cellular cavity, which it will, because if you take out a big tumor, all of a sudden the whole thing can fall down and cause visual deterioration, which can happen. Overpacking of the cella must be avoided. I've seen this, people doing that and causing visual problem, and you may have to go back and take that pack out if the vision goes off in these patients, and you cannot just overpack, it's not possible. Lumbar drain, obviously intraoperative CSF leak, if it's there, and if it's a large leak and you've got a big area in which you need a repair, and you need that repair to hold, then lumbar drains can be helpful. Closure, if you think it's not watertight, you think that you may be causing leak, or there may be dodgy areas which you're not sure of. And an extended approach is sometimes we use lumbar drain. Hemostasis, well, if there's a bleeding and prolonged operative time and problems identifying tumor and normal pituitary gland is not seen, and all that is when you've got blood trickling down all the time. And if you're experienced, you know where exactly the gland is, you can get away with it. But when you're not experienced, you're going to abort the operation prematurely, and that could cause residual tumor to remain, and you may be causing serious problems or harm to the patient if there's a lot of blood hanging around. So there are tricks. You can have a warm water irrigation. You put your bipolar in ice cold tubs. So basically the edge of tips of the bipolar are kept in ice cold water. So once you're using bipolar, or they may be non-stick, but they will never stick again, and they will work really well. And we do the same thing when we are doing phosphorus tumors or brainstem lesions that we are trying to take out. Bone wax with patties works very well in instances when the bleed is from the bone, and especially in the acromegalics. And you can have xylocaine with adrenaline patties or cocaine patties or gel foam. Obviously, cotinide in patients is the way to go. In certain cases, we do use flow seal, but it's expensive. And in countries like us, we have to make sure that we keep the cost down. Although flow seal works very well in certain cases, may be the way to go. So let's come to how endoscopy has changed the way we used to work. And is it possible to take out more tumor and give better results to our patient when we are using endoscopy? So this paper came out in 2013 in Journal of Neurosurgery from McLaughlin's group, which is a Dan Kelly's group from UCLA. And they had 140 patients, and they divided them into patients who had microscope-based tumor removal, endoscopic-based tumor removal, and they realized that when they were using microscope and when they put the endoscope in later on, found that in 1/3 of the patients they were able to take out more tumor in which they thought they had finished the case. In these 73 patients, this was shown in 2014 that the resection rate were up to 82%. In endoscopic surgery, and gross total resection was up to 24% in patients with giant pituitary tumors. And 73% had improved visual acuity, and about 1/4 would remain unchanged. Majority of these patients did not have any serious complications, and they had statistically significant predictors that the resection rate was high if the NOS grade was low, or if the preoperative tumor volume was low. Obviously, maximum tumor diameter, hemorrhagic component, posterior extensions, and sphenoid sinus invasion also decides how much tumor you'll be able to remove. So if you look at surgically treated giant tumors, prostatan resections were much better with bilateral endoscopic transsphenoidal surgery, comparing it with craniotomy or with a microscopic-based transsphenoidal surgery. And the results were completely different, that with bilateral endoscopic surgery, the resection rate were up to 90%, whereas craniotomy and microscopic-based transsphenoidal surgery was only 60%. There's a huge difference here, and gross resection rate were much higher in these patients. So endoscopic endonasal surgery comparing with microscopic and open surgery clearly shows differences. And another cohort group of patients literature review with 478 patients showed that highest rate of gross total resection was in endoscopic group compared to microscopic group. So huge differences here, 50% versus 10%. Visual outcome much better with endoscopic group, whereas half of the microscopic group improved. No post-operative leak in the endoscopic group in this particular area. And obviously the perioperative mortality was high when transsphenoidal, when the transcranial surgery was employed. So endoscopic endonasal surgery safe, effective, reducing the CSF leak, improving the visual outcome and overall survival in these patients. This is actually a picture from north of Pakistan, a resort called Shangri-La, which is all these mountains are in the range of 4,000 meters plus. And I was there, I was lucky enough to go there last summer, and it's an amazing spot to be there. So I thought I'd just show this to you. Our own experience with giant pituitary adenomas, we have had 90 of those, and we have had these patients last were followed up a couple of years ago. We had eye and endocrine, neurosurgery, radiology opinion, resection rates were assessed. In these patients, 13 patients had two-stage surgery when the extension was into the third, when they had a heart tumor, when they had dumbbell tumor, and they had not come down. Two of these patients required a CSF diversion procedure first when they presented to us in comatose position. The type of pituitary tumor also is shown here among these patients. So we had 16 patients which had functioning, in which 10 were acromegalic, 5 were Cushing, and majority of these were non-functioning tumors. Sorry, I don't know if I can show this. Let me see. Can you see this clearly? John, can you see this?
Yes.
Okay.
We can see this clearly.
So, see this patient with acromegaly and a little bit of bleed on the top and extension going laterally. So it's NOS grade 4. And if you look at Hardy's, if you look at that, and it's grade 4 as well. And this is post-op, and this is just done endoscopically without any problem, because majority of this was already down into the sella, move tumors. So despite being dumbbell shaped, they are easy to do. Is the slide moving forward here?
You're still on the slide, which shows the, yes, presenting symptoms is now.
Yeah, I think I'm just going to stick to this. And if I have to show something, then I'm going to move there. So if you look at these 9 patients with giant pituitary tumors, the majority of them presented with headache and visual deficits, and 10 of them presented with apoplexy, and 4 in comatose stage, and 2 of them required CSF diversion procedure. Visual findings were majority of the cases, as you can expect, had problems. 5 had cranial nerve palsies. So if you've got a tumor like this, which is lying all in the sella and just expanding laterally, obviously they are easy to remove compared to a tumor that is arising way above the sphenoid and then going up all the way and causing problems. So adenoma height, if you look at the 200 patients that we are looking at, of those
Good morning. It's Dr. John Bennett broadcasting from Miami. We have a seventh Neurosurgical Super Sunday. Today we have the pleasure of having Mike Cherian, the head of the Nepal Neuroscience Center in Biratnagar, Nepal, and we're joined with a full panel of people from around the world. Let's introduce the panel first before we turn it over to Ike. Hello, Adnan. Please introduce yourself, please.
Hello, good morning, everyone. I'm Adnan Mohammed, yes, neurosurgical resident in the second year, Egyptian. Nice to meet you all.
Thank you for coming, Adnan. And Amna, could you please introduce yourself?
لا ما فيش كاميرا هنا.
Yes,
Hello?
we can hear. We can hear.
I
Go
am
ahead,
Nagori.
Amna.
I am Nagori. I am a fresh medical student from Dow Medical College, Pakistan.
Very good. Welcome, Amna. And Francisco.
This is Francisco. I'm a neurosurgeon in Hospital Virgen del Rocío from Seville, Spain. I'm happy to be here.
Yeah, welcome, Francisco. And Salman, can you say hello, please?
Hi, John. Hi, all of you guys. Good to see that this is growing and getting better as we progress.
Salman, Yuha and Sergi is here.
Great. Hi, guys.
Welcome, Shahira. Can you please introduce yourself?
Hi everyone, I'm Shaira Hashmi, a fresh graduate of Dow Medical College, Karachi, Pakistan.
Yeah, welcome, Shahira. And Slaven?
Thank
you. Slaven?
Hello, everyone. Slaven, I'm Megusin from Zagreb, and I'm the leader of Dandy here, and I'm really happy to be here for another and Dr. Ernest Nyamito.
Thank you, Slaven. Yosef, could you please introduce yourself? Yosef, you're muted, so Yosef. Whoop, you're muted, Yosef. Okay, Yosef is a med student from Pakistan. I guess we'll continue on to the Russians. Can someone from the Russian? It's not
Hello?
quite a full. Oh, yes, hi. How you doing? Welcome back.
Hi there.
Okay, I recognize them. Okay, I welcome, and it's all yours.
Okay. Yeah. Guys, I'm going to start screen sharing. See, I was a bit preoccupied, but the last week at least I had more than 6 people asking me a lot of doubts on Dawlings again on the Facebook, and then I've told them that I'm going to show you a cadaver dissection. So I was searching for it. Fortunately, I got this cadaver dissection, which was done 2 years back. So this is in my previous medical college in Chitwan. So I'm going to show you this cadaver dissection, and we'll go through the steps. So I'm going to share now.
Okay.
All right. Can you see, guys?
Yes, we can.
Okay. So here we go. We've done subfacial. People call it interfacial, but it could be subfacial also, subfacial dissection. So you can see that subfacial dissection there. Now that is the root of zygoma. If I need a petrosectomy, then I make an incision like that, around the ear. So then the middle fossa approaches are always based on the root of zygoma. So here, we don't need all that. So we're going Dawlings, taking it all off, the temporalis muscle. Anybody, what am I doing? What point is that? That is the orbit. That is the orbit.
Okay.
That's a keyhole. And always in this point, you find an inferior orbital fissure. I will show you the inferior orbital fissure there. Well, we don't do this in actual cases, but you can always find out the inferior orbital fissure there. And then you always have a pad of fat, large pad of fat there, with which you can reconstruct a lot of defects. So you really don't need to. So I'm going to dissect out the periorbita completely, and then dissect down to show the zygoma. So zygomatic arch is being dissected out. This is the main part of Döhling's. If you miss this, then you are not going to be able to do a good fronto-orbitozygomatic approach. So you can see that how is the muscle coming in. You know, the subfacial dissection there, and how the muscle goes in. Now the zygoma, the orbit, everything has to be nicely identified. Each has to be identified. You make your burr holes there. You make your burr holes there. So that is your hockey stick drilling. That is your hockey stick drilling. That's your keyhole burr hole. That's your keyhole burr hole, and that's your hockey stick drilling. So the hockey stick drilling goes along the zygoma. And that is your next hole. So you're going to do your craniotomy there. So this is a two-piece orbitozygomatic craniotomy. One piece is much more easier actually, but we're going to show you a two-piece now. The sphenoid ridge is there. This is a normal pterional craniotomy, but you see that's a sphenoid ridge, and you can see the beginning of the orbitomeningeal band. You can see that band there. Everybody sees this. People stop their biting there. So that is the orbitomeningeal band. So can you see that? That is, can you identify, anybody identify what is that for me? I have taken the temporal floor flush, so I can see this cranial nerve exiting. What is that cranial nerve? Anybody? There is another cranial nerve here going out.
Yes, it's the optic nerve.
No. This is not the optic nerve. This is
I'm sorry.
V2.
Yeah.
This is V2.
V2. Forgive me.
That's V2, and this will be V3 here. Okay, so the optic nerve will be somewhere here. Slaven. This optic nerve will be somewhere here. So optic nerve will be here. 3, 4, V1 will be going to the superior. This is superior orbital fissure is going to come here, and that's a temporal. That's behind V2. This is V3, and then after that is a Kawasaki triangle. So we are slowly going from front to behind. I have incised the orbitomeningeal band now, and I'm going to dissect the orbitomeningeal band, and you can see the there is a superior orbital fissure. This is a superior orbital fissure. You will see all the cranial nerves. That is a antideclinal process, and I'm going to dissect the antideclinal process free now. That is the antideclinal. That's optic now. This is the antideclinal process. So the TCM is completely intact. If I cut through here, the TCM here also will be intact. See. So you can see that is a Gazerian ganglion. And that band is the GSPN. GSPN you don't see as a nerve. If you are a good skull base surgeon, if anybody tells you that the GSPN is a nerve, no, don't believe him. He has not done. So that is your Kawasaki triangle. That is your Kawasaki triangle. This is exactly how you see it in the real life scenario also. So that is a Kawasaki triangle. That is a Kawasaki triangle there. That is a Gazerian ganglion. That is a V3 there. That is V2 there. And that is a GSPN. That is a GSPN. That is a Peters ridge. And arcuate eminence will come here. That is a meatal. That is a meatal depression. IAM should be coming somewhere here in this direction. In this direction. That is a meatal depression. So you identify. Sometimes there is a double ridge. So you don't want to be fooled. So you always see where is the dura. You trace the dura, you always see the dura. So you have a GSPN there. You have your lateral to GSPN, you have your eustachian tube. Underneath the GSPN, you will have your carotid. And that is your V3. That is your Kawasaki triangle. So generally, I drill this V3 and I take this Gazerian ganglion up and I can drill beneath that triangle also. So for petroclavial meningiomas and all, I prefer this. There is much more easier than a retrosigmoid if the petroclavial meningioma is in the correct location, way anteriorly. So that I am showing them where is the GSPN and where is the IAM coming. What is the angles? What are the angles? Right now, we are back to the cavernous sinus again. You can see V1, V2, V3. That is the fourth nerve. That is the third nerve. Third and the fourth nerve. And this is the cavernous sinus. This is the cavernous sinus. And you can see the carotid. C4 carotid there. That is the C4 carotid. And underneath that is the sphenoid sinus. And you can see one more nerve coming medial to the V1. Lateral to the carotid and medial to the V1. What nerve will that be? What nerve will that be? Just medial to the V1? Anybody? That is the sixth nerve. Medial to V1, lateral to carotid, just lateral to carotid. That nerve is sixth nerve. So that is fourth nerve. That is third nerve. Optic nerve, carotid, third nerve, fourth nerve, that is the tentorial edge. That is the tentorial edge, which is actually related to your distal dural ring. So cavernous aneurysms, if you cut the distal dural ring and then you shave off this, you are reaching the C3 vertical carotid. Each of these triangles can be opened once you take care of the TCM. But if you want to go inside, you have to inject glue. So that is your ACP resection. ACP is being taken off now, drilled off. The last part of ACP is taken out between the optic nerve and the carotids. So that is the last bit of this ACP. The optic strut is also being taken out. You can see the carotico-oculomotor membrane. The carotico-oculomotor membrane you can see. And if you take off that carotico-oculomotor membrane, you will see the carotid, the C3 carotid. That is a sharp tooth of the ACP. That is a C3 carotid. This is the vertical segment is in the cavernous segment. So the cavernous aneurysms are generally situated around here. So you can go medial to the third and the fourth nerve, and then you can get into this space. If the aneurysm neck is in C3, this is an aneurysm which can be clipped by the modified or even the classical Dowling's approach. Classical Dowling's approach is a little bit more, I will say, traumatic. It is because TCM is not preserved. It's really bloody. So, but modified Dowling's where the TCM is preserved, this is a straightforward approach. I mean, for a skull-based surgeon, right? So we are just seeing the anatomy. We are shaving off the tent. You can see the third nerve entering into the oculomotor trigone there. That is intradural. So the third nerve is entering into the oculomotor trigone, and you can see the intracavernous third nerve now. You can see the entry point of the third nerve there. That is a fourth nerve. That is a Parkinson's triangle. That is a Parkinson's triangle between the fourth nerve and the V1. And that is your Kawasaki triangle. We will learn. So you can see V1, V2, V3. You can see GSPN, and you can see the Peters ridge here. And you will see the IAM here. You can dissect further on the GSPN. It goes underneath the superior petrosal sinus. You can cut the superior petrosal sinus, clip it, clip the superior petrosal sinus, cut the superior petrosal sinus, cut the tent and connect it to the connect this fossa to the posterior fossa. And after taking this off, you'll get a huge space. So most of the sphenopetroclavial meningiomas, if they are soft, it is I will not say easy to take it out, but you can take it out. It's difficult, but you can take it out. Much better access than a retrosigmoid. So that is your area of the lamina terminalis. That is your optic chiasm. So that is your third nerve going into the interpedunculair fossa. That is your carotid. Different windows. Stalk, region of the stalk. So that is your entire Dowling's window. That is your Dowling's window. And you can combine it with the Kawasaki window to get a huge exposure. Well, thank you. So again, I want to show you in a live case the same thing. We have seen it different times. So again, the same thing being done. Orbitomeningeal band being excised, cut, sharp dissection of the orbitomeningeal band, sharp dissection of the orbitomeningeal band, peeling, Peeling. Yeah, peeling is, as the ladies peel, for the face mask and peeling and all that. This is peeling, okay? Once you cut, peeling is easy. If you don't cut, no peeling. Sharp dissection first and then peeling. If you peel from the beginning, the plane which you peel will be completely different. Then you will get into cavernous sinus. And in a live case, if you get into cavernous sinus, it is not pleasant, you see. So peeling now. It's peeling. Clinoid process being outlined. That is a clinoid process. Root. C3 carotid, clinoid process completely taken out. C3 carotid now. That is a carotid. Now dural opening. Optic nerve. Very tight brain here. Carotid, optic nerve. Posterior clinoid process. Here you don't need to drill the posterior clinoid. This is P1. P1. Superior cerebellar artery. Carotid. Membrane of Lilliquist is open. That's a PCP. You put the drain and come out. Right. Thank you very much. Questions, if there is anything, please ask.
Okay, thank you very much for your excellent presentation, and we'll open the floor up to comments or discussion. Slavin, would you like to comment or question or have any questions for Ike?
Yeah, I just wanted to comment that you should never cheat on a test, because Francisco was there trying to unmute and he was showing 2 fingers, and I went optic without thinking. So it's my
Okay, Francisco,
although I
you
knew it wasn't so. Yeah, yes.
Well, I'll try to
You should never
unmute
cheat
now,
on testing.
Francisco. I'll try to help you. Go ahead, try to unmute now. Can you do it? Oh, you can, I guess.
Yeah, it seems that he cannot unmute, but I'm a witness,
Oh, there we go.
witness
There we
that
go. Go
he
ahead,
knew
Francisco.
all the answers.
We can hear you, Francisco.
Yeah, I just wanted to. I was trying to say V2 with a finger.
Yeah, me too. I understand. It's
Okay, do you have any
troublesome,
questions
but
or
it's
comments
great.
for Ike, Francisco?
No, excellent presentation. I'm very thankful.
Okay. Well, I don't know if you introduced yourself, Francisco. Do you know Ike?
No, I never knew him. Now I know he's an excellent neurosurgeon from Nepal.
Okay, yes, he's a big proponent of cysternostomy, and I'm sure you'll be hearing about that. And I'd like you to introduce you to a neurosurgeon from the Canary Islands, Kevin. Kevin, could you say hello to Ike?
Hello, good afternoon. Can you see me?
Yes, we can see you. We can hear you.
Yeah, because I have any problem to connect today. Hello, good morning. My name is Kevin. I'm from Canary Island. For me, the presentation from IPA is perfect. So I have not any question.
Okay, Kevin is interested possibly in visiting Nepal.
Yes.
Hopefully, and hopefully you'll get to know him. And I highly suggested it to Kevin.
Yes. Yes, because we have 6 months to visit another hospital and to learn different specialty from neurosurgery.
Okay.
So I am interested to visit this hospital in Nepal with Ipe. But if I have any opportunity, for me, it's perfect.
Okay, sure. Well, I guess we can talk later about that, right, Ike? Ike, you're muted. You're muted, Ike.
You are welcome. You're very welcome to come here.
Okay, thank you very much.
Yes, he'd like to do that. I highly recommend it. Okay, any other questions? Any comments or questions from the Russian contingent? It's quite sparse today. Hello, Russia, come in.
Coming in.
Okay,
They are coming in.
there's movement there.
Thank you very much, Professor Cherian. One question: how we can dissection membrane from the paternal approach?
I didn't get you.
Dissection of membrane of Liliequist from the paternal approach.
Okay. Yeah, I got you. Yeah, the membrane of Liliequist is the membrane of Liliequist is something between the anterior systems and the posterior systems. So it's something between your optic and carotid, as well as your carotid and third nerve. So to section it, you have to understand that there are two major arteries running right underneath it, which is your PCOM and your anterior choroidal, running between the optic and the carotid. So it will come into this window. So you have to be a bit careful there. So if you know the position, if you irrigate frequently, you will see these arteries for sure, and you can section it without any problem. Also, you can follow the third nerve and keep cutting the arachnoid into the interpedunculaire system. You can also, if your opticocarotid window is too small, then you can use the lateral carotid window, which is lateral to the carotid, and you can follow the third nerve, incising the arachnoid of the third nerve, and then you will reach the interpedunculaire system where your basilar quad is. So you can approach either way. The angle is different. Sometimes you can go, if you are going supraorbital, then also you will need to do the posterior clinoidectomy in this case, but even then, in one of these windows, you can reach the basilar quad. So I don't think it is a very straightforward. It took me some time to figure out how to, how to section it properly. But if you go between these two windows and be careful, you will definitely, you can section it.
Okay, thanks, Abe. Okay, any more comments or questions from the Pakistani students? Any comments or questions from Amna or Shahira?
No.
Okay, that's no problem. Okay, another comment from Russia.
Video about dissection of membrane.
I didn't get you.
Have you video about dissection of membrane Liliequist?
Yeah, there are so many videos. I have 700 videos. So if you want, you can go to look in the YouTube. You can look in the YouTube under Raju Cherian. You can just type Raju Cherian on YouTube, and then you will get many videos. So you type cystonostomy on YouTube, you will get many videos. So if you want, maybe I can show it again sometime.
You know, you have a page dedicated to you on Neurosurgical TV. Neurosurgical TV /IPE. We have a lot of your cystonostomy videos on that link, and I'll send it also to the Russian contingent. Okay. Okay, Adnan, any questions or comments? Are you still there, Adnan, from Egypt? Okay, I guess we're ready. We'll just sing directly to Yuha. Is Yuha ready, Ike?
Yeah, Yuha is ready.
Okay.
I'm just.
Okay, very good, Joseph. You got that. You had room. Thank you for giving up your seat temporarily.
Thank you very much. John, we need another link.
No, the same link. Same link. This is, we're going to continue on with Juha's presentation. I believe he's going to talk about brain tumors.
Is this there? No, it's
Okay.
going from there.
Before you start, how you doing, Juha?
I'm fine. I'm fine.
I'd like to introduce you to the panelists before you start, okay?
Okay, I try to find my videos now.
Okay.
Thomas? Thomas? Yeah. John?
Doesn't show.
You can show anything.
Yeah, I know. So, no, I think. No. No, this one? Can I begin?
Yeah, okay. Yeah.
I'm sorry, I had to search for the videos. I will show 3 cases of posterior fossa meningiomas, and I begin from below.
1 second, I have to screen share.
Okay, let me start formally. I'll introduce you, Juha, and we'll go around and introduce the panel first, okay?
Yeah, after that we'll screen share. Okay.
Yeah, let me know when you're ready, Juha. We'll edit all this out.
Yeah, so I will show you 3 cases of posterior fossa meningiomas, one foramen magnum meningioma, one cerebellopontine meningioma, and one clivus meningioma. So I will show rather long videos, so you see the details also of this surgery. So it will take around 45 minutes, maybe 40,
Okay,
45.
let me just introduce the panelists first, okay, Juha?
Thank you.
Hello, Adnan, could you say hello to Juha, please? Adnan, are you still there? I guess not. Okay, Amna, could you please say hello to Dr. Hernaz-Niemi?
My name is Amna Ghori. I am from Pakistan and I'm a fresh medical graduate from Dowmed, University of Health Sciences.
Yeah, welcome, Amna. And Francisco, could you say hello to Dr. Hernaz-Niemi, please?
Hello, Juha. This is Francisco from Seville. Happy to hear you.
Thank you. And Kevin, could you say, introduce yourself to Juha, please?
Hello, good afternoon, Juha. Nice to meet you. I'm from Canary Island. and I want to participate in this conference and to learn of you.
Welcome from the Canary Islands. Shahira, could you please introduce yourself to Juha? Oh, well, you're muted, Shahira. You're muted. You're muted. Unmute yourself.
Okay, could you hear me now?
Yes, we can
Can
hear
you
you.
hear me now?
Yes, we can.
Okay. Okay. Hi, Dr. Juha. I'm Shahira from Dow Medical College. I'm a fresh graduate.
Welcome, Shahira. And Slaven?
Pakistan. Yeah.
Welcome,
thank you.
Shahira. Slaven?
Hello, I'm Slaven from Zagreb, and I'm happy to hear another one of the great Dr. Juha's lectures. Thank you so much.
Thank you, Slaven. And Yusuf, could you please introduce yourself to Juha?
Hi, Dr. Juha. I am a final year medical student from Dow Medical College. Looking forward to hear you. Thank you.
Well, welcome. And the Russian contingent.
Hello, it's Russia. It's Federal Center of Neurosurgery. We're happy to see you, Professor Hansemi.
You're welcome. Welcome on the Russian contingent. Thank you. Okay, Juha, it's all yours.
Okay, let me go
Yes.
for the video presentation. So, yeah, where to go?
I'm screen sharing now, guys.
Okay, no. Good. Yeah.
Can you see? Can you
Yes,
see, guys?
yeah, we can see it. We can see it.
So this is for a magnum meningioma, 81 years old patient, and has tetraparesis, slight tetraparesis, and these are the symptoms. An old patient, of course. This is Parkman's position, and I make the approach here rather low. So it is lateral suboccipital approach, rather low. I used to do this approach under microscope, also from skin beginning. Why? Because there are extremely important structures at the foramen magnum, vertebral artery. Here you have bleeding from emissary vein, best to be stopped by some hemostat pushed inside the emissary vein hole. Or then I use also glue, sometimes bone wax also there. And these curved retractors are extremely good in the lateral suboccipital approach or posterior fossa approaches. So I like to use them, curved retractors. Yeah, and then under microscope I open straight the muscle. So you could, of course, spend a lot of time dissecting the muscles, yeah, but I have found it very practical and fast to dissect the muscles. This is monopolar cutting power, and then cleaning all the time and palpating here. This is right. So this is now you see terrible bleeding coming from large vein. How to stop that? I push hemostat there inside, coagulate to shrink the vein, and then I push glue there. So this is one of the possible methods. If you have heavy bleeding there, you should take the head higher, but here we could manage that well. And I like to do everything under microscope because you see the bleeding point very well, and then your hemostasis is appropriate. And now I'm searching for vertebral artery here. So we are on the left side and searching for vertebral artery. I palpated the C1 arch, and now still again bleeding, again bleeding, condylar emissary vein. So bleedings. You have to take care. Don't go forwards if you have bleeding. So otherwise your surgery is not clean and nice. So this is hemostat, push there, and then So you see that I know that main part of this the video is opening and there are tricks in opening. So if you just show the tumor extirpation, then you are not showing everything. So you see, I have high magnification. I'm doing the craniotomy here, very small craniotomy to the foramen magnum. I'm doing under microscope. This side cutting craniotome, and then I have a very small bone plate, which I first some holes for dura tenting sutures, and then I drill more bone, and then I take the bone out and drill. On the left side, I drill foramen magnum open with diamond drill, carefully drilling. And you see that I'm not using here a lot of water, because I want to, with the drilling, a good hemostasis is achieved. So this is what we call hot drilling. Drilling with the diamond drill, so you have at the same time extremely good hemostasis in the bone. So a little bit lateral parts are now removed, and I go laterally here. How far? I always say that enough far, and it depends on the lesion what you are taking out. I never make standard approaches, so tailored approaches. Yeah, hemostasis, and then now opening of the dura. I open the dura here before removing all the bone, just to see the situation intradurally. And I use many times rather plump scissors. This is a regular dura scissors because it doesn't hurt intradurally the structure. So it is good to open that way, and hemostasis all the time at the jugular tubercle. And now after opening the dura partially, I drill still more of the jugular tubercle because I noted I need a little bit more removal. And using the Garrison wronger here, after thinning the bone with diamond drill, I remove more bone, enough laterally to remove the tumor totally. And then more drilling to remove bone, but at the same time also to stop the bleeding, hemostasis, hot drilling under microscope. Okay, and then I open more. This is the ligament here, and open more dura, and then when removing foramen magnum meningioma, you have to have extremely strong, tight sutures here. So you will see that I will put extremely tight sutures, and then we have the tumor. We can see the tumor soon. Well, now it looks very confusing, but now we see the tumor, and we have a very good approach to the tumor, foramen magnum tumor. So this is ligamentum denticulatum. I cut here. Now you see that I can move the tumor. Tumor is hard, so it's difficult to make in small pieces. So maybe I should cut it. I coagulate the tumor and stop the bleedings around. Bleedings look very large because there's high magnification, and I manipulate the tumor all the time now. Now I think I should cut the tumor in pieces. You see, this is microschizo. It looks extremely large under high magnification. I manipulate the tumor, push it downwards, and cut it in pieces because the tumor is hard. So coagulate, tumor, orientate here, and make it avascular. Where is the tumor attached? It is laterally attached, and anteriorly the feeders are coming from there. But of course, in that kind of tumor, very hard tumor, it is not so vascular tumor. So main difficulty is here, of course, that the consistency of the tumor is very, very hard, so you have to make it in small pieces. I'm using here schizos, mechanical forces to make the tumor smaller. I think CUSA would not bite anything here. So I seldom use CUSA in tumors, only in intramedullary tumors and some gliomas. So now we go forward in making the tumor in small pieces. The manipulation looks very much here because it's a very high magnification. So and it looks that there's a lot of violence, but it is not so. So small feeders, coagulated, cut. You have to be very careful not to take a artery. It might go to medulla oblongata here. So you have to be completely sure that it's going inside the tumor. And now I take the tumor with tumor forceps, cut, coagulate more, cut more. And then the tumor is coming. Come on. So now I should to clean the field. I should clean the field. Oh, it looks not good. Not good. And this is Doppler. I'm searching for vertebral artery. And coagulate attachment to the dura. Base of the tumor laterally and anteriorly. Now beginning to do hemostasis here. Laterally, I push hemostat here. I'm not so happy with the anatomy here. I asked the operator to clean the field. The tumor is out now, and you see that I make the hemostasis there. Laterally, use large pieces of the hemostat, pushing them laterally to the base of the tumor, and I also cover the dural defect with the large hemostat, and then the bone plate is use blue here. You may ask if there's a CSF leak. No, there's no CSF leak. So this is very safe and good method. So this is postoperative. You see the tumor has been taken out, and the patient did very well and had her tetraparesis symptoms gone. So then we take next posterior fossa tumor. This is a cerebellopontine angle meningioma. So around 1/5 of the meningiomas are located in posterior fossa infratentorial. So I have done around 1,400 meningiomas, so you can count how many infratentorial then. And this cerebellopontine meningioma, rather high. Again, I make a park bench position. There was a nevus in the neck, and the patient asked to remove it at the same time. So the incision is a little bit different according to the nevus location. And this is now the right side, and the opening is higher. In the former case, it was a foramen magnum meningioma. So we made a low opening, and we went close to the foramen magnum, and where the artery is carefully opening. And here we do make a higher opening, 2 retractors, and then 1 burr hole, and detach the dura here, and then we make lateral suboccipital approach here. This is retrosigmoid approach. I make 1 burr hole there, and then 2 cuts laterally, and then drill laterally the bone partially like that, and then break the plate away. So this is the retrosigmoid approach. Bone plate broken away, and then laterally drilling of the bone away. Putting a green around the, and then opening the dura laterally. You may open differently. You may open only very laterally, straight incision, but I like to do that way because you get better hold on dura with the stitches. And this is water dissection. Dissecting inside the space, and now we came immediately to the large tumor. And now we see right 7 and 8 nerves, facial, statoacousticus, and then below that 9, 10, and 11. And as you know, I'm using cottons without strings. So because here, especially in posterior fossa, the strings might go around the cranial nerve, so I don't like them. So I use cottons like that. And now the tumor seems to be rather soft, so I can suck it, manipulate. It's coming in larger pieces. Maybe we can go a little bit forward here. All the time I use also water dissection here and draw pieces with 2 more forceps out, and also suck all the time and dissect with the left hand with the sucker. And here, cleaning the field, dissecting with water again, and then coagulating, tumor feeders, cutting with microscissors, and a large piece of tumor is coming out. Now I should clean the field up. It looks dirty, the field. Now dissecting between the cranial nerves. And then I put hemostasis here on the brainstem, and it helps in further dissection. Now I take the cottons out and the anatomy is getting more clear again. Give water, clean the anatomy. And then extremely careful hemostasis now. Especially posterior fossa, if you have postoperative hematomas, then the patient might deteriorate extremely fast. So you have to have extremely good hemostasis. Always good hemostasis, but some areas extremely careful hemostasis. So even the smallest bleeding taken, and then with the help of the hemostat pushed on the brainstem, checking everywhere. There's a small arterial bleeding. Small arterial bleeding. Taking that carefully. Now clear the field, clear the field. There was a big tumor, so there's a large area to cover with the hemostat. And, of course, you can do differently, but I learned to like this hemostat. And here you see the postoperative pictures next day. Total extirpation of the tumor. And then we go to the third case. And it was a clivus meningioma. So you see a large or medium-sized meningioma, and it's growing from the clivus and partially from petrosum. And my principle is usually that I do the lateral tumors I do in the park bench position and midline tumors in sitting position. This is left side opening under the microscope, and as I mentioned, important structures at the cranial, the cervical junction. So this is the vertebral artery, so you have to take very good care of it. And one of the important things is here the palpating finger to find the C1 arch, and then Doppler for identification of the vertebral artery, so about the C1. And here this is the fatty triangle. See, here you have to be very careful, very careful. So if you go too low, then you have a lesion in the first in the venous plexus around the vertebral artery, and then also in the vertebral artery. So carefully doing. I like to do it under microscope and with the help of Doppler. So you have to sure where the vertebral artery is running. Then a small plate is lateral suboccipital craniotomy is done. So you see that this clivus meningioma is approached through retrosigmoid approach. Simple approach, fast approach, very atraumatic approach. It doesn't take half a day to do the approach. It is done in half an hour. So I think the trend in taking also skull-based tumors out is that you can go to small, simple approaches without losing all your energy in doing the craniotomy. And here, dura is opened again. Similar to the case of foramen magnum meningioma, rather low approach because we have to go also rather low to the tumor, clival tumor. These are tenting sutures here. and the movement is coming all the time. I have here's a hypoglossal nerve. Movement in the picture is coming that I'm using a mouthpiece. And why I'm using mouthpiece in the microscope? Because it makes the surgery so much faster. You save 40% of your time. 40% of the time. And now cutting arachnoid around the lower cranial nerves. And here listed 9, 10, 11. 9 and 10 are the most important cranial nerves for human life, because if you have lesion in 10, so the patient is apt to aspirate and may die after operation. So you have to take utmost care of these nerves. And also when you wake up the patient, you have to check carefully if they are functioning or not, even anatomically intact, so before extubation. So here the tumor is coming, lower part of the tumor is seen here, dissected away from the lower cranial nerves, and then I go with pipola inside the tumor, coagulate the surface, and all the time manipulate the tumor, cut with microscissors, the opening bigger. And I go laterally and anteriorly, because the feeders are coming from there. So you have to always go to the feeders of the meningioma first. Then you have a dry tumor. And here we know that the feeders are coming from the attachment from clivus and os petrosum. And here I use a pipola again. There was a schizo and tumor forceps also could be seen. But main time I work all the time with sucker and pipola and then schizos. And here I go laterally to the base of the tumor. The base of the tumor. Because when you have the base cut and coagulated, then the tumor is dry. And you can draw it away. All the time working away from the brainstem. So coagulating tumor and then pushing it laterally away from the brainstem, shrinking the tumor, making it hollow. Cleaning the field, also injecting the water between tumor and brainstem pons. And I push the forceps inside the tumor and use them like as a fork to retract tumor away from the brainstem. All the time working between cranial nerves and shrinking the tumor, manipulating, drawing it, gamma, not too much violence here. Carefully under high magnification, shrinking the tumor and taking small parts away, debulging the tumor, then cleaning the field with water dissection, dissecting the tumor away from the brainstem, and as mentioned, all the time, away from the brainstem, working away from the brainstem. In this tumor, there's a good cleavage plane. So you see, there's a good cleavage plane. I put cotons there also, and coagulate the surface of the tumor. Now I think I should cut the tumor in 2 pieces, so to get it slowly out. Coagulating the surface now. We slowly get the surface that was against pons. Compressing pons, we get the surface here, and then we coagulate it and shrink it, and taking good care of the arteries here. Here is the artery. This is don't take it. This important artery. small artery close to the brainstem. You should dissect it carefully. And here we see the basilar artery below the basilar artery in all its length. It was attached to the tumor. In many times it looks in the pictures that the basilar artery is inside the tumor, but it is not so. There is a small sulcus and you can dissect it away. So here, basilar artery in all its lengths, and you should have to take care also for the perforators of the basilar artery. So now I cut the tumor in smaller pieces. And all the time dissect the tumor away from brainstem, away from basilar artery, or away from pons. Shrink the tumor. And now you see that I have made the tumor smaller. There are smaller pieces, and I can coagulate the remnant of the base, cut, and so slowly get rather big pieces of the tumor to be borne out. I can draw them slowly out, but you should always be extremely careful when you draw parts of tumor or arteriovenous malformation out. So there's always one vessel left. And here I coagulate still the base of the tumor, meningioma, to get all the feeders and to get the tumor part loose under high magnification. And I think the big nerve here is a trigeminal nerve above. Again, coagulating the tumor base laterally, anteriorly, the clivus. And slowly, the big parts of the tumor are born through the windows between the cranial nerves. Here, a very big tumor part is born. And making this tumor smaller with microschizos. And again here, very small but important artery under high magnification. So you should never take them before you see that they are going to the tumor. Mainly they are going around the tumor and feeding the brainstem and pons. So here. Working between cranial nerves, important arteries. Tumor is slowly taken out, slowly and slowly. So it doesn't take whole day, just few hours. So big pieces of tumor are coming out now. What is this artery? I think it's ICA. And now laterally coagulating, anteriorly coagulating the base, carefully destroying the tumor there, taking tumor out, coagulating. There is an angle if you don't work. And here you should use ice hockey forceps. So to go behind the corner to coagulate all the base of the tumor. Otherwise you left tumor there easily. This is the experience. So using ice hockey forceps, like ice hockey clap, and then cutting all the time tumor remnants, coagulated tumor remnants away. And again, extremely good hemostasis. And this is the result, and this is, you see, very good, nicely looking postoperative MRI. So these were the cases I wanted to share you. So posterior fossa meningiomas at different levels, foramen magnum meningioma, cerebellopontine meningioma, and then clivus meningioma. The last one, technically most difficult, and without good surgery, you will have many deficits in the patients, and the outcome usually good, but you might have serious complication if you make errors there. So I cannot come back to the screens share. Can you hear me?
Yes, we can hear you. Yes.
Okay, but I don't find I went somewhere. I don't find the place for screen sharing now. So I have to stop now because I cannot find. I went with the patient. So I thank you very much for your. If you have any questions, I can hear and answer the questions, but I cannot find a way to screen sharing now.
Yes. Thank you very much, Professor Juha, for another presentation series, and I would like to ask members of the panel, I'm sure they have some questions, so please you have the opportunity to ask now. Maybe our team from Russia has some remarks. Yes, Salavat is coming.
Hello, Professor. My name is Salavat. I have one question about retrosigmoid approach. What landmarks do you use? Transverse sinus, sigmoid sinus, and their junction?
I didn't understand the question. So retrosigmoid approach. So you make a lateral suboccipital approach. I make it in backbench position and straight incision, and make one burr hole, like was shown, 2 cuts, and then drill the base laterally, and then crack the bone plate out, and then drill more laterally. In most cases, you should drill so that you see the margin of the sinus, the transverse sigmoid sinus.
Okay.
Okay, now it's coming master of screen sharing. Yeah. Okay,
you can continue. Great.
Thank you. Some more questions?
Any more questions, please? Maybe Yusuf has some remarks, or Kevin, or Shahira.
Yeah, the presentation was great, Dr. Juha. Wish to see more of them. And thank you.
Thank you, Yusuf.
The presentation was absolutely amazing, Dr. Juha. And no, I don't have any questions. Thank you so much.
Thank you for attending. Okay, so Professor, it seems that your presentation was quite clear. I see the Russian team is coming to the stage.
Professor Khanisnimi, and one more question. What do you use for CSF sealing FOSSA operations?
Careful closing, but you saw that I'm using hemostats and then tissue glue a lot, tissue glue. So I never had difficulties with CSF leak. So this is a usual question, and in my practice, of course, the wounds were closed by experienced neurosurgeons, fellows, under microscope. So I think this is one of the important points that you close under microscope. You have a very good closer, and then you take good care of the dural deficit. But I never, as the old classic style that you speak about watertight closure, but I never have done it. I have used hemostats and glue to seal the defect exactly, and I never had difficulties with CSF leak from the wound, and I'm very unimpressed.
Thank you.
Yes, Professor Cherian looks very neat in the back. You have some maybe. I
have a meeting.
You have a meeting. Yes, it looks like that. Well. Thank you for this. Another really super Sunday, and I am really happy to be part of this series, which I think is really forwarding the overall base of knowledge in the world of neurosurgery. And thanks again for all the presenters.
Thank you very much.
Cherian and Dr. Khanisnimi. And thank you so much for giving us the opportunity to learn from you. Although we are distant, we are using the best of the new technologies. So
Okay,
any
Slaven,
closing
thank you.
remarks? Yes, thank you, Dr. Cherian. Any closing remarks from you?
Well, as you have seen, I mean, somebody asked about the CSF leak. It almost always never happens in posterior fossa unless you have really bad technique. Of course, I mean, if you open into a mastoid cell or if you open into something which is unwarranted, yes, that can happen. But usually, if you close even without watertight technique, it never happens. So we also do this, and I never do watertight closure. I do not. We used to do earlier, but we don't do watertight closure, so there is no problem. Thank you again.
Okay, thank you all again. Shahira, you wanted to say something, or was it just a cough?
No, it was just a cough, sorry.
Okay. Thank you all for attending. Again, it is a true privilege to end this conference, and we will meet you for the next one exactly in 1 week. So have a great meeting, Dr. Cherian. Thank you for everything to you, Dr. Juha, and others, and have a pleasant Sunday.
Thank you, everybody.
Goodbye to all of you.